Hello. Today's lecture will address the behavioral objectives of week 3 in the syllabus. Because the file is so large, this will be presented in 2 parts. Please make sure you watch both parts to avoid missing critical information. This is part B for week 3. Okay, so make sure you watch part A of week 3. So here what we're going to do is we're going to talk about the growth and development of the adolescent. This is a period of rapid growth. Males develop more lean muscle mass, females increase in body fat percentage in preparation for childbearing. Puberty begins because of hormonal changes. It follows a certain pattern. Primary sex characteristics are the internal and external organs that carry out the reproductive functions. Secondary sex characteristics are changes that occur throughout the body but do not have a direct role in reproductive function. The primary sex characteristics in the female are the ability to develop and release an ovum. The FSH stimulates estrogen production in early puberty but doesn't cause ovulation until mid-puberty. The primary sex characteristics in males is the development of viable sperm. FSH stimulates testicular cells' secondary sex characteristics, stimulating the production of viable sperm, also known as spermatogenesis. FSH and LH act on different cells. LH increases the secretion and production of testosterone. The development occurs in a set sequence. Tanner identified 5 stages of secondary sex characteristic development and genital growth development. This results from an increase in hormones. Please refer to your book for the pictures. Sexual development in females in sequence. The first sign of puberty begins between 8 and 13 years of age, which is the breast development, which is the bud stage in the areola and around the nipple. These areas begin to protrude. Generally, this is complete at menarche. It is not uncommon for breasts to be asymmetrical. Height and weight increase next. Pubic hair, then axillary hair, develop after bud development and increase throughout middle adolescence. It's normal to have a vaginal discharge, physiologic leukorrhea. In early puberty, it's associated with uterine development. Menarche. The age range here is between 10.5 to 15 years of age, with the average age being 12 years and 8 months for Caucasians and 12 years and 2 months for African Americans. First menstruation occurs 2 years after bud development. Pregnancy can occur at this time. Usually they are irregular and they may not ovulate with regularity, and ovulation usually occurs about 6 to 14 months after the first menstruation. Menarche is the hallmark of late puberty. Developmental delay occurs if there is no breast development by 13 or no menarche 4 years after bud development. The growth spurt is between 9.5 and 14.5 years of age. Growth in height generally ceases 2 to 2.5 years after menarche. Generally, girls don't grow more than 2 inches after menarche. About 95% of adult height is reached at the onset of menarche. On average, girls will grow between 2 and 8 inches and gain 15.5 to 55 pounds during adolescence. Sadly, for a variety of reasons, many girls are unhappy with their appearance. Next, we'll talk about the sexual development in males, and we will do so in sequence. So the growth spurt occurs approximately 10.5 to 16 years of age, usually about 2 years later than girls. The height growth stops about 18 to 20 years of age. They usually grow about 4 to 12 inches in height and gain 15.5 to 66 pounds. Lean muscle mass grows throughout puberty, but it's peaked during early puberty. The first puberty changes are testicular enlargement, followed by thinning, reddening, and loosening of scrotum tissues. And this typically begins about 9.5 to 14.25 years of age, 1 year before the growth spurt. Sexual development is considered delayed if there's no testi-scrotal changes by the age of 14, or genital growth is not complete 4 years after testicular enlargement. Pubic hair begins to grow early and continues through late adolescence. Facial hair begins usually starting with the upper lip and middle adolescence, about 2 years after pubic hair develops. There's a rapid increase in height. Voice changes occur because of the growth of the laryngeal cartilage. And then the ability to ejaculate occurs about a year after testicular enlargement and pubic hair development. Viable sperm may occur at this time. They may also have nocturnal emissions, which is a normal physiologic reflex to ejaculate the buildup of semen. Please make sure that the male knows that this is not bedwetting and this is a natural process that can occur when sleeping. The penis will lengthen and widen during puberty, but there's a significant increase in size during the mid to late puberty. Facial, axillary, chest, and pubic hair thickens and is increased in amount throughout puberty, beginning primarily in mid-adolescence. Gynecomastia may occur between 14 and 17 years of age, and this is a breast enlargement and tenderness that can occur in up to 70% of boys during mid-puberty. It typically disappears in about 2 years, usually the end of mid-puberty. In general, this is for both male and female, apocrine sweat glands start to function during adolescence. So there may be an increase in body odor that is present. The eccrine sweat glands continue to function. Bone growth follows a linear pattern. First the feet, then the leg length, and then the trunk and shoulders, and lastly the chest. So basically they will outgrow their shoes first, then their pants, and the shirts last. Nutrition. Growth can double in adolescence. Nutrition requirements for iron, calcium, zinc, protein are increased at this time. Girls are especially prone to iron deficiency during menarche and deficiency in folic acid B6, vitamin A, calcium, and zinc. This especially occurs in lower socioeconomic areas. Girls need approximately 2,200 calories during puberty, depending on their level of activity. Boys, early puberty, 2,500, mid is about 3,000, and then late is 2,900. Again, this is determined also by their level of activity. High calorie, fat, sugar, cholesterol, and sodium are found in all races and both sexes, regardless of socioeconomic studies. Status. About 21% of adolescents are obese. About 0.5 to 1% of teens have anorexia nervosa. And here we see this actually more in middle and upper class Caucasian females. Less than 10% of people with anorexia are male. Fast food tends to be very popular in teens. They often skip breakfast, very concerned with their body image. Often being very busy can affect what they eat. And then please remember, their friends, their peer group gives them a sense of belonging. Physical activity. More than 60% of students do enroll in PE. Physical activity, about 1/2 of high school students engage in activities that made them sweat for 20 minutes. Some have a physical activity daily or almost daily as a part of games, work, play, transportation, recreation, PE, or other planned activities. After 10th grade, unfortunately, many do not have a required physical education class in high school. The recommendation is moderate and vigorous activity at least 3 days a week for an hour. Sleep. It's not uncommon for a teenager to need 10 to 12 hours of sleep during the growth spurt. After that, they require about 9. It's not uncommon for them to go to bed very late and then they wake up very late. So there's a growth and development table in your textbook, so we're going to go over that now. So early adolescence, this is roughly 11 to 14 years of age. We're going to look at cognition. Here they are exploring their newfound ability for a limited abstract thought. They are comparing normality with their peers of the same sex. In terms of identity, they are very preoccupied with their rapid body changes and they're trying out various roles. The measurement of attractiveness is determined by the acceptance or the rejection of their peers, and they generally tend to conform to the group norms. Relationships with parents, here they're beginning to define those independence-dependence boundaries. There is a strong desire to remain dependent on the parents while they're trying to detach. This is not a time of major conflict. Relationship with peers. Here they seek peer affiliation to counter instability generated by rapid change. There is a struggle for mastery that is taking place within the peer group, and this helps to give them a sense of belonging. They have an upsurge of close idealized friendships with members of the same sex. Sexuality, really here it's limited dating, usually group dating, and limited intimacy. Psychological health, here you have wide mood swings, intense daydreamings, and you might even see some anger outbursts. They may be moody, temper outbursts, and even verbal insults and name calling. Middle adolescence, this is 14 to 17 years of age. Here, in terms of cognition, they're really enjoying their intellectual powers. They often are very idealistic. They have a big concern for philosophic, political, and social problems. Identity, here they're identifying their body image. They tend to be very self-centered and they have an increase in narcissism, and we're going to talk more about that shortly. There is a tendency towards the inner experience and self-discovery. They have a rich fantasy life. They tend to be very idealistic. Although they're able to perceive future implications of current behavior and decisions, they don't always utilize that information. Relationship with parents. This is where conflicts tend to occur. Here, independence and control the child is trying to become more independent and gain more control. This is the low point in the parent-child relationship. This is where there's that greatest push for psychological disengagement. Relationship with peers. Here there's a strong need to identity and to affirm their self-image. Their behavioral standards are set by their peer group. So basically what we're seeing here is pay attention to what their friends are doing because often they may be doing the same things. Acceptance by peers is extremely important. They do have a fear of rejections. And then there's an exploration of the ability to attract whomever they're going to be sexually attracted to. They may have multiple plural relationships, so like dating a lot of different people. And it is at this time that they're really able to determine what their sexuality is. There is an exploration of self-appeal, that feeling of being in love, and then a tentative establishment of relationships. Psychological health. Here there's a tendency towards inner experiences. They tend to be more introspective and withdrawn, especially when they're upset or their feelings are hurt. They have a hard time asking for help. Late adolescence, 17 to 20. Here, that abstract thought is pretty well established. They can perceive and act on long-range operations. They're able to view problems more comprehensively. Identity, the body image and gender role definition is nearly secure. They have a more stable self-esteem, and their social roles tend to be fairly well defined and articulated. The relationship with their parents, here, that emotional and physical separation from the parents is often complete. Because there is an independence from their family, there's a little bit less conflict. Relationships with the peers. So peer group resides in importance in favor of individual friendships. So here basically what we're seeing, instead of having large groups of friends, they're more paying attention to those really good individual friendships. Also, the relationships with whoever they're sexually attracted to, they understand that they are characterized by giving and sharing. Sexuality, they tend to form a stable relationship and have an attachment to another person. There is a growing capacity for mutuality and reciprocity. Intimacy involves commitment rather than exploration and romanticism. And again, dating will occur with whomever it is that they are attracted to. Psychological health here, they're more constant in their emotions, so they're much more stable. They're not up and down as much. And then if they do become angry, they are much more able to control and conceal that. So teens are often very self-centered, and some patterns of self-centered thinking that are common to the teen include the imaginary audience. This is the thought process of where they believe that everybody is focused on what they are doing. They believe everyone is watching them. The personal fable is that their feelings and experiences are completely unique to them, which means nobody understands what they're going through because they've not experienced what they've experienced in the past. And then lastly, the feeling of invulnerability. This is the attitude of, it will not happen to me. This is the one that's sort of on the dangerous side because this can cause adolescents to be reckless and have poor impulse control. And then this puts them at high risk for accidents and injury. Sexual activity has actually decreased over the years, but there's been an increase in HIV and STIs. Unintentional pregnancy has also dropped. Schools usually teach sex education or health class around the 9th grade. Teens need to understand the dangers of alcohol, drug use, and smoking. They need to see that STIs, pregnancy, and addiction can happen to them. As a nurse, you need to assess these different areas and talk to them about different ways of being sexually active. And then ask them, in what ways have they been sexually active? We don't want to refer to a boyfriend or a girlfriend. You want to refer to a partner because you don't want to stereotype. Also, you want to ask about their friends. Do their friends smoke, drink, use drugs, chew tobacco, have body piercings or tattoos? Piercing and tattoos are a concern because of infections and problems with developing blood-borne pathogens. You want to discuss why it's dangerous, what the effects can be towards themselves, school, work, friends, and family. We do want to avoid lecturing. Please note that 70% of 12th graders used alcohol in the past month. 40% smoked using cigarettes and in the past month, and 46% used cannabis in the past month, one research showed. So please, by asking, what are your friends doing? Then we can infer, are they doing that as well? So if they say that their friends drink or use drugs, then you can ask them how often they do so. In an adolescence, after injury and homicide, suicide is the third leading cause of death. You need to assess, does the adolescent feel down, blue, sad, depressed? Do they think about hurting themselves? What do they think about doing? Do they have access to the method? When would they actually do it? Remember, the more thought out the plan, the higher the risk of suicide somebody has. If somebody tells you that they are suicidal, remember, you cannot keep this confidential. You have a legal mandate to report it. Gay and lesbian children are at especially risky for suicide, especially when they live in communities that are not accepting of homosexual people or non-cisgendered people. The most common method used in completed suicides is firearms. The most common method used in attempted suicide is overdose. Social isolation is the most significant factor for distinguishing a person who will attempt to kill themselves from a teen who will complete a suicide. So as a nurse, definitely please assess for changes in behavior and teach parents to assess for changes in their child's behavior as well. Are there any changes at school? Are they giving away their belongings? Remember, the presence of a gun in a household increases the risk of suicide by 5-fold and homicide by 3-fold. A male who has guns at home is the highest risk to commit suicide. Injury prevention during adolescence. So what are the abilities related to the increased risk of injury? They have a need for independence and freedom. They're testing out that independence. They may actually be able to drive. There is that inclination for risk-taking. They have that sensation that they are indestructible. They have a lot of energy and they need to get rid of it. A lot of times they're not thinking about the risks of what they are doing. There is a strong need for peer approval, so they may attempt hazardous feats. And they also have access to complex tools, and then they may participate in sports that may cause injuries. So injury prevention. So motor vehicle and then non-motor vehicle accidents. So pedestrian, emphasize and encourage safe pedestrian behavior. If they are walking at night, walk with a friend. If somebody is following you, go to the nearest place with people. Try not to walk in secluded areas and take well-traveled walkways. If you are a passenger in a vehicle, obviously keeping all of your body parts in the car, avoid distracting the driver, and make sure you've got your seatbelt on. The driver, you want to provide competent driver's education. Make sure that they are not street racing or playing chicken or doing any other kind of dangerous activities in the car. You want to maintain the vehicle in proper condition, meaning that the brakes work, the tires have tread on them, and so on. You want to teach and promote safety and maintenance of two-wheeled vehicles. Promote and encourage wearing safety apparel such as a helmet or long trousers, especially if they're like on a motorcycle. Reinforce the dangers of drugs, including alcohol. Obviously, you don't want to be under the influence in any way, shape, or form when operating a motor vehicle. Also teaching them in order to prevent drowning, making sure they know how to swim, make sure that they understand water safety, and if they are diving into the water, making sure it's plenty deep and to always swim with somebody. In terms of burns, here you want to make sure that they avoid excessive sunlight or wear sunscreen, and also avoiding sunbeds because anytime someone goes to get a tan, that is actually dangerous. That encourages the development of skin cancer. You want to discourage smoking, and again, make sure that they utilize sunscreen when they are outside. Poisoning, again here, talking to them about the hazards of drug use and alcohol use, and also avoiding vaping, because that is also very dangerous. Falls, teaching and encouraging general safety measures in all activities. Here we want to make sure they're not walking and texting at the same time. Bodily damage. Here you want to have proper instructions for sports and making sure that they're using the proper sports equipment and safety gear when they're participating in sports. Teaching them a respect for firearms if they are in the home. Also teaching them to be safe with power tools if they're allowed to utilize them. Promote access to and provision of safe sports and recreational facilities. Be alert for signs of depression as well as signs of suicide, thoughts of suicide. Discourage the use of hazardous sports equipment like trampolines. Instruct regarding the proper use of corrective devices such as glasses, contact lenses, and hearing aids. And then we also want to encourage and foster judicious application of safety principles and prevention. So that completes the growth and development for pediatric people. Please note that although this is for week 3, it is important for you to know the growth and development for all of your exams. Next, we're going to talk about SIDS, Sudden Infant Death Syndrome. This is a sudden unexplained death of an infant under a year of age. It's the 4th cause of death between 1 month and 1 year of age. Some risk factors include low birth weight, prematurity, are they a twin or triplet? Race in decreasing order frequently includes first Native Americans, followed by African Americans, Hispanics, whites, and then lastly Asian infants. Gender is more common in males and females. Age, most common in infants between 2 and 3 months of age. 95% of cases occur before 6 months of age. Time of the year, it's more in the winter. Also, if they're exposed to passive smoke, that increases the incidence. Do they have a history of cyanosis, respiratory distress, irritability, and poor feeding in the nursery? Prone position, soft bedding and overheating, co-sleeping, especially with an adult smoker. So we always say children should not be in the bed with the parent, but they should sleep in their own crib in the parent's room on their back. Maternal and familial issues that can help to contribute to SIDS. Maternal age less than 20, a history of smoking and or illicit drug use, anemia, multiple pregnancies with short intervals between births. Is there a history of a sibling with sudden infant death syndrome? This actually increases the incidence 4 to 5 times. Do they live in a low socioeconomic status? Do they live in a crowded house or apartment? Poor prenatal care, low weight gain. Some protective factors that can help to prevent issues with SIDS are that Back to Sleep campaign. So all infants birth to 6 months of age must be placed on their back when they're going to sleep. We also want to put them to sleep with a pacifier. A thin blanket can be placed on the infant as long as it's tucked in at the level of the waist. Really nothing soft should be in the crib, so they don't need stuffed animals and thick blankets or pillows. None of that should be in there. Infants should not sleep in the parent's bed, but we do want them in the parent's room. Infants with GERD may be placed supine unless there is a condition with a higher risk from death than SIDS. And this is only as directed by their doctors with extreme caution. So what happens when a parent, experiences a child that dies from SIDS? What do we need to know and do as a nurse? First, we need to obtain the history by the parent or the other caregiver. You want to ask them, what time did they find the infant? How did the child look? Who called for help? Was there a change in the infant's position? Was the blanket disheveled? Was the infant clutching it? Was there frothy blood-tinted secretions from the nose and mouth? Often the parents will find the infant in the morning after a quiet night. Often this also can occur after a mild respiratory illness. An autopsy typically reveals pulmonary edema and intrathoracic hemorrhage. Nursing interventions in the emergency room. We want to provide the parents with a private area and a support person who can help them with the child's death and reinforce that this was not their fault. Parents need to be able to express their grief in their own way and know that they're not being blamed for the infant's death. Prepare the family for the viewing of the infant. Let them know how the child is going to look and feel. Also refer to the child by their name. Be very empathetic. Allow the parents to hold, touch, and rock the infant if desired. Viewing the infant allows the parents a chance to say goodbye. As a nurse, before bringing the infant to the parents, make sure the child is clean. Wrap them in a clean blanket, comb the hair, wash the face, swab the mouth, and apply a little Vaseline to the lips. Reinforce the physician's explanation about the need for an autopsy. An autopsy is required for all unexplained deaths. And you can say to parents, it's really the only way that we can be sure of what caused the child's death. Answer the parents' questions and provide them with sources for further information. Provide literature and a name of the local contact for a SIDS support group. Parents may not be able to take in all of your answers at that time, making sure that they have resources for future use. Many emergency departments and pediatric units have a social worker that will provide ongoing contact with the family. Provide names of resource persons and phone numbers for SIDS support groups. Advise parents that surviving siblings may benefit for psychological support. Siblings often require emotional support in the weeks and months after the death. Social workers can help the family. Siblings, excuse me, please make sure that the social worker can help the family get counseling and support for all of the family members. As a nurse, we can provide the parents with a lock of hair, footprints, and handprints if they desire. It's like a memory card. These personal items can be placed in the memory book. This reaffirms the child's existence for many parents. There is something else called an ALTI. It used to be called an acute life-threatening event. Now we're calling it a BREW, which is a brief, resolved, unexplained event. Also, you might hear this referred to as a missed SIDS. Here what happens is the child experiences color changes, hypotonia, choking, gagging, and they may require CPR. This condition can be associated with an increased incidence of SIDS. What we do for this condition is they may be placed on a home apnea monitor. They may need medications like methylxanthines and caffeine, and the parents and anyone who is caring for that child must be trained in CPR. Next, we're going to talk about the respiratory system and conditions we may see in children that have respiratory problems. So the respiratory system. Respiratory problems are the most common cause of illness requiring hospitalization in kids 15 years and younger. Until about 6 weeks, even up to 12 weeks of age, infants are obligatory nose breathers and they can only breathe through their nose. So they don't know that they can breathe through their mouth. Typically, they only breathe through their mouth when they are crying. An infant's trachea is the approximate size of their pinky. So if you need an ET tube, it will be about that size, which if you think about is really very tiny. There are a wide variety of differences between the upper airway between the children and adult. Just know that the tracheal cartilage is immature. They may easily collapse when the neck is flexed. Because they have fewer muscles and that are functional in the airway, it's less able to compensate for edema, spasms, and trauma. They also have large amounts of soft tissue and loosely anchored mucous membranes lining the airways, and this can increase risk for edema and obstruction. They also have a small oral cavity and a large tongue, and this can increase risk for obstruction as well. Apnea. So this is when there's a breathing pause for 20 seconds or more. This is definitely a concern. So our first disorder we are going to talk about is nasopharyngitis. Basically, this is the common cold. It's caused by a wide variety of viruses, and this can be prevented with frequent hand washing. Signs and symptoms. In a younger child, we might see fever, irritability, restlessness, sneezing, vomiting, and or diarrhea. The older child may complain of their nose feeling dry and irritated, as well as their throat. They may have sneezing, chills, muscular aches, and cough. Typically, it resolves in 4 to 14 days. Treatment. We're going to be treating the signs and symptoms. So if they have a fever, we will give them an antipyretic. Typically, we want them to rest until the fever is gone, plus 1 day. So generally, if a child has a fever, we do not want them going to school. And the day after they don't have a fever, they also should be staying home. Topical decongestants for infants over 6 months of age would be appropriate, and prior to that, you may use normal saline drops. Decongestants work by causing vasoconstriction, so please be careful if the child has type 1 diabetes, because remember, this vasoconstriction is systemic. Dextromethorphan, this is a cough suppressant for a dry hacking cough. We use this very cautiously in children under 6 years of age. The American Academy of Pediatrics does not recommend cold medicines under 4 years of age because it's really just not that effective. You want to elevate the head of the bed at least 30 degrees for easy respirations. They may require oxygen with humidification or a cool mist humidifier. We do want to maintain the SaO2 greater than or equal to 95%. Check vital signs and lung sounds. They may also use a bronchodilator if prescribed. Keep the child calm. Provide with appropriate diversion activities. If they need suctioning, we limit that to 5 seconds. You want to feed the infant with many breaks using a calm approach, and we don't want to take longer than 30 minutes. Explain everything to the parents as you go along. Typically, the child who has a common cold or nasopharyngitis is managed at home. If the child isn't getting better in a couple of days, then you may need to give the doctor a call. Pharyngitis. This can possibly be caused by strep throat. So if it is caused by strep throat, this is a group A beta hemolytic streptococcus, and the signs and symptoms you can see here are tonsillar exudate, a very severe sore throat, fever over 101, headache, petechial mottling of the soft palate, vomiting, abdominal pain, swollen painful lymph nodes around the cervical area. And diagnosis here, they can do a throat culture with a rapid stress test, and this is ready in just a few minutes. Treatment, amoxicillin or penicillin V for 10 days orally. They can also use an oral macrolide like azithromycin or erythromycin if they're allergic to penicillin. And they use the same type of palliative treatments as tonsillitis, which we're going to talk about in a moment. They are no longer contagious after 24 hours. So it's important to change the toothbrush 24 hours after they've started antibiotics so they don't get reinfected. You want to wash all the mouth appliances thoroughly, like retainers or if they have grinding guards. If they're not getting better within 24 to 48 hours after the antibiotics have been started, give the doctor a call again. So tonsillitis. So this is inflammation of the tonsils that is caused by a virus or a bacteria. We just talked about bacterial tonsillitis, which is the strep throat. Signs and symptoms here include a sore throat. The throat hurts with swallowing. They may have breathing difficulty, fever, tonsillar swelling, which can result in tonsils being so inflamed they actually touch each other. We call those kissing tonsils. Swollen lymph nodes, pain that refers to the ear, malaise, and decreased food intake. Diagnosis is a physical assessment. Again, they will do the throat culture to determine whether it is a virus or a bacteria. We only give the antibiotics if it's a bacteria. Some symptomatic treatment includes warm, normal saline gargles, lozenges as appropriate for children over 3 years of age. We don't give lozenges under 3 because they can choke. Antipyretics, warm or cool compresses to the neck, and then giving soft, cool foods and rest. So a tonsillectomy and or an adenoidectomy. This is indicated for multiple reasons, including recurrent strep infections, also peritonsillar abscess or hypertrophy that causes problems with eating or drinking, sleep disordered breathing, and then there are many, many other reasons that they will do TNA. To do surgery, they will need to wait until the child is free from any signs and symptoms of upper respiratory infections for at least 1 week. So they need to have no signs and symptoms of an upper respiratory infection, no fever, no sore throat for at least 1 week. And usually the adenoids are removed if they have obstructive sleep apnea, otitis media with effusion, or the recurrent rhinorrhea. Post-op care includes positioning on the side or the abdomen for draining, Drainage. Avoid suctioning except to remove an obstruction. Monitor for signs and symptoms of bleeding. Here you might see frequent swallowing, restlessness, a fast, weak pulse, vomiting bright red blood. Typically, the bleeding will occur mostly within the first 24 hours, but there is actually a membrane that can form over the surgical site, and if this dislodges, which it could do so anywhere between 7 and 14 days after the tonsillectomy, it's important for parents to know that that frequent swallowing is an early sign of bleeding. They may use an ice collar or viscous lidocaine as a swish and swallow to help for pain. We want to teach them to avoid coughing, nose blowing, gargling, and throat clearing, because this can cause issues with the surgical site. They may have ear pain 5 to 10 days after surgery, and this is a referred pain that is normal. They may use oxycodone or hydrocodone for the first 24 to 48 hours after surgery, and then regular acetaminophen afterwards. Once they are able to swallow, they are fully alert, and there's no signs of symptoms of bleeding, they may start off with diluted fluids, like a diluted juice, and then soft foods. You want to provide clear, cool, non-citrus fluids. You want to avoid foods and fluids that are red and brown in color, because we want to be able to see if somebody is bleeding. You want to avoid milk, ice cream, and pudding, because it can cause a child to clear their throat and then disrupt the surgical site. Influenza. Couple of different types, types A and B. This is more common in the winter. You are most infectious with influenza 24 hours before the onset of signs and symptoms. It is spread via direct and indirect contact, and it typically lasts 4 to 5 days. Signs and symptoms is that dry throat and nasal mucosa. They can have a dry cough. They may be hoarse. They may be light sensitive and have body aches. They may be very weak. They may have a fever and chills. We can prevent this with the flu vaccine. And really, we say at 6 months of age, children should be getting the flu vaccine. In general, we treat them symptomatically with ibuprofen or acetaminophen. We want to give them plenty of fluids to maintain hydration. Oseltamivir can be given for 5 days orally within 2 days of the onset in children a year and over. This is good for types A and B. If the child has a prolonged fever or an appearance of a fever during early convalescence, this can indicate that the child has developed a secondary bacterial infection. It's necessary to report this to the physician, because then the child may need antibiotics. In general, the flu is not treated with antibiotics. They can be treated with antivirals. They are only given antibiotics if the child develops a secondary bacterial infection. Do not give aspirin or non-aspirin containing salicylates because of the issue with Reye syndrome. So remember, we can prevent the flu in children with the flu vaccine 6 months and older. Next is otitis media. Here, there's a high incidence between 6 months and 2 years of age due to the wider, shorter, straighter eustachian tube. It then decreases after 2 years, but then there is again a little spike between 5 and 6 years of age, and then it's uncommon after 7 years of age. Signs and symptoms. Acute otitis media. Here we see an inflammation of the middle ear space with a rapid onset of acute infection. It typically follows an upper respiratory infection, ear pain, fever. They may or may not have purulent drainage. An infant or a very young child may be crying, fussy, restless, irritable. They may be rubbing, holding, or pulling the affected ear. They may roll their head from side to side. They may be difficult to comfort. They may have an issue with their appetite. Older children may cry and verbalize feelings of discomfort. They may be irritable, lethargic, and have a loss of appetite. For a child that has chronic otitis media with effusion, they can actually develop hearing loss, difficulty communicating, a feeling of fullness in their ear, tinnitus, which is the ringing of the ear, or the vertigo may be present. Diagnosis based on the signs and symptoms. So they'll take a peek into the ear with an otoscope. With acute otitis media, you can see sort of like a reddish yellow and bulging tympanic membrane with no light reflex or bony landmarks. Otitis media with effusion, they'll have an immobile tympanic membrane, slightly inflamed orange membrane with obscure landmarks, and you might even be able to see fluid behind the tympanic membrane. Treatment. So in general, they may do a watch and waiting to see if the symptoms get worse for up to 72 hours in infants that are over 6 months of age. That is okay. Antibiotics are given for acute otitis media if the infant is younger than 6 months of age due to the immature immune system, or younger than 2 years of age with acute signs and symptoms of fever and severe ear pain. The first line of antibiotics is typically amoxicillin, 80 to 90 milligrams per kilo a day for 10 to 14 days. Sometimes they need it for a shorter period of time, maybe only 5 to 7 days. Second line of treatment includes azithromycin, cephalosporins, or amoxicillin clavulanate. A myringotomy sometimes may need to be performed. This is an incision into the eardrum that can be done using a laser if there is severe pain or hearing loss. They may also insert pressure equalizing tubes if they have frequent problems with otitis media with effusion. Basically what they will do is they help with drainage and ventilation of the middle ear. If this occurs, doctors have a wide variety of treatments of what they say you can and cannot do. Some will say they do not want any water to go into the ear. Some doctors will allow swimming in chlorinated water. Soap or shampoo should not enter the ear, and this can be prevented by putting a Vaseline-covered cotton placed into the ear or using earplugs. Know that the tubes may fall out. This is not an emergency. Just call the doctor the next business day. Often they will remain in place for 6 months to 18 months, and they'll fall out during this time as the eardrum heals. If they're still there more than 2 to 3 years, then they are removed. Something to help with pain and allowing the ear to drain. If it does have drainage, having them lay on a heating pad can be beneficial. Children that have frequent otitis media can have issues with hearing loss. So if they have fluid in both ears for a total of 3 months, it's important to do a hearing evaluation. There are different ways to help to prevent otitis media. Things like feeding the child in an upright position when with bottle feeding or breastfeeding, immunizations, pneumococcal conjugate, as well as the Hib. No smoking around the child or in the home. Do not prop bottles. Decreasing or stopping pacifier use after 6 months of age. Pain and fever typically decrease within 24 to 48 hours, but please make sure that the patient is taking all of their antibiotics. Next, we're going to talk about epiglottitis, and this is a type of croup. This is a bacterial croup syndrome. It's an inflammation of the epiglottis that occurs most commonly in kids 2 to 5 years of age. This is a medical emergency. This is usually caused by Hib, the Haemophilus influenza B. Signs and symptoms: rapid onset. They are agitated. They can have stridor or frog-like breathing on inspiration. They're in tripod position. They may have a sore throat. They may have an absence of a spontaneous cough. There are 4 Ds for epiglottitis, and that would be dysphonia, dysphagia, drooling, and distressed respiratory effort. They can have a high fever, a rapid heart rate, and rapid breathing. This is a child who looks very ill. Diagnosis: they will do a lateral neck x-ray, and here you can see a large round epiglottis and a narrow airway. In this child, please do not examine the mouth or do a throat culture, because this can cause laryngospasms, and then it would be necessary to intubate this child emergently. Treatment: it may be necessary to intubate this child, so please make sure all of the items necessary to do so is at the child's bedside. They will be getting antibiotics, either cephalosporins or sulfas, for 10 days, and then antipyretics as well. If they are intubated, this child is in the PICU. Typically, after 3 days of antibiotics, the epiglottis returns to near normal size, and then they can be extubated and taken out of the PICU. Often they will be given high humidity, or they can be placed in a cool mist oxygen tent. We want to keep them upright, keep them calm to prevent laryngospasms, continue antibiotics, plenty of fluid for hydration, monitor intake and output, weight, vital signs, SaO2, and full respiratory assessments. We want to support the family emotionally as well as the child. The child is going to be very anxious and fearful because the parents may not be there, also because it's in a strange place with strange sounds. It's very important to allow visiting 24 hours for parents, to allow them to be there. Also, please make sure to explain all the care to the parents. Parents are very anxious too because they are in a place where they don't know what's going on. So this is why it is so important to explain everything in the PICU to the parent. Laryngotracheal bronchitis, also called LTB. This is also a type of croup, but this is a viral infection of the larynx and the trachea. This is seen in 6 months to 3 years of age in children, but primarily in children under the age of 5. Here, the signs and symptoms have a much more gradual onset. They have the signs and symptoms of respiratory upper infection, and then they develop an inspiratory stridor, sort of like a seal-like barking cough. They can have hoarseness, shortness of breath, irritability, and a low fever. This can develop in 4 stages. The first stage is fear, hoarseness, croupy cough, inspiratory stridor when disturbed. The second stage is continuous respiratory stridor, retractions of the neck and the lower rib cage, accessory muscle use, and labored breathing. Stage 3, here they have signs of anoxia and carbon dioxide retention. They may be restless, anxious, pale, sweating with rapid respirations. Stage 4 is intermittent cyanosis, permanent cyanosis, and cessation of breathing. Diagnosis, they'll do a physical exam. Again, we're going to avoid throat cultures here, and an inner mouth exam on a child, because here we're concerned with the potential of epiglottitis. So until we know what's going on, we're going to just avoid that situation. An upper airway x-ray will be done, and here this will reveal symmetrical subglottal narrowing. This is called steeple sign. We also will monitor the SaO2. Treatment is humidification. If the SaO2 is less than or equal to 92%, they do require oxygen, and we want that humidified oxygen. They may be given racemic epinephrine, corticosteroids, and albuterol. These help to dilate the bronchial areas, and they reduce bronchospasms and edema. You want to have plenty of fluids to thin the secretions. If the respiratory rate is greater than 60, there'll be NPO, and the reason is because we don't want to have issues with aspirations. If their signs and symptoms are mild, so if they're only in stage 1, they may actually just be able to stay home and then teach the parents the signs and symptoms. If their respiratory distress is becoming worse and they progress to stage 2, then they need to come back to the hospital. So as a nurse, we need to be monitoring their vital signs, their SaO2, the respiratory status of their effort, stridor, retractions, color, level of consciousness. Know that as breath sounds decrease and the level of consciousness changes, this child is becoming sicker. You want to position the child in a comfortable position. As they sit up more upright, please know that they're having more respiratory distress. Check the child often for the inability to swallow, drooling, or decreased voice sounds. The quieter the child gets, the worse the situation. The child can actually become physically exhausted and then go into respiratory failure. Bronchitis. This is an inflammation of the large airways, usually associated with an upper respiratory infection, often viral in nature. Signs and symptoms include dry, hacking, non-productive cough that becomes productive in 2 to 3 days, in addition to the signs and symptoms of a upper respiratory infection. The treatment includes analgesics, antipyretics, humidity, cough suppressants only to allow the child to rest and sleep at night if they're over 6. Please note that some studies show that honey is very effective in treating coughs. This typically lasts anywhere between 5 and 10 days. Bronchiolitis. This is typically caused by respiratory syncytial virus, RSV. This is an infection that causes inflammation and obstruction of the small airways and bronchioles, often seen in children ages 2 years and less. Typically, we see this more in the winter and spring. So the signs and symptoms start out as an upper respiratory infection, initially rhinorrhea, pharyngitis, coughing, sneezing, wheezing, possible ear or eye drainage, fever, and the illness can then progress with an increase in coughing and wheezing, air hunger, tachypnea and retractions, cyanosis, and then further progress for a more severe illness with tachypnea greater than 70 breaths a minute, listlessness, apneic spells, poor air exchange, and then poor breath sounds. Diagnosis. Here they can do a nasal swab or a nasopharyngeal wash for RSV. If positive, place a child in droplet and contact isolation. Please note, sometimes there are big outbreaks of RSV, and it is okay to place 2 children in the same room if they both have RSV. Treatment, vital signs monitoring, the SaO2, monitoring the lung sounds, the effort of breathing, assessing for the cough, intake and output weight, providing humidified oxygen to keep the oxygen above 90%, hydration via IV or oral. They may be on nebulized treatments, bronchodilators, and or steroids. Know that ribavirin, which is an antiviral agent, it's an aerosolized treatment to decrease the severity of RSV. This is only used for high mortality risk infants and transplant patients. Most often you're going to see this for premature babies. The problem with this medication is that it has severe teratogenic effects. You must protect pregnant health caregivers. When using this medication, if you're going to access the tent, turn the medication off so the particles don't go all over the place. The skin does not absorb the medication, so gowns and gloves are not required when handling the medication. Maintain the head of the bed elevated. Do chest physiotherapy and suctioning only as needed. We want to maintain adequate rest for the child. Encourage the parents to visit, ask questions, and provide ADLs. Also making sure that the parents do know how to use a bulb syringe. There is a medication, palivizumab, also called Synagis, that can be given every month times 5. It's an IM medication, and this is used selectively to prevent RSV infections for high-risk groups. So this is very commonly given to children that were born prematurely. The powder needs to be used once it's reconstituted within 6 hours because it does not have preservatives in it. Discharge instructions. Here you want to call the doctor if there's any respiratory rate increasing, if there's an increase in shortness of breath, if they're not eating or sleeping, if they look more fatigued, if the child is looking or acting sicker. Persistent signs and symptoms in a child less than a year of age, if they have heart or lung disease, or they are premature, please make sure that you do contact the physician. Next, we will talk about asthma. This is a chronic inflammatory disorder of the airway. Clinical manifestations include coughing, hacking, paroxysmal, and it may be non-productive. It can become rattling and productive, and then you can see frothy, clear, gelatinous sputum. Respiratory-related signs. Here we would see shortness of breath, a prolonged expiratory phase. You can have an audible wheeze. Then it can go to a decreasing wheeze, and then absent wheezes with increased rate, because this can actually mean impending respiratory failure. So remember, decreasing breath sounds is an indication of respiratory failure. They can have a malar flush or red ears, and the lips may be a deep dark red. This can then progress to cyanosis of nail beds and or circumoral cyanosis, restlessness and apprehension. Sweating may be a prominent as the attack progresses. Older children may sit upright with their shoulders in a hunched over position and their hand on the bed or chair and their arms braced. Remember, this is what we call tripod position. They may speak with short, panting, broken phrases. The chest, what does it look like? They may have hyperresonance on percussion. They may have coarse, loud breath sounds. They may have wheezing throughout the lung fields. Please note whether it's inspiratory wheezing, expiratory wheezing, or both. They can have prolonged expiration. They can have crackles. Remember, wheezing is that high-pitched tone. With repeated episodes, they can develop barrel chests, elevated shoulders, use of accessory muscles for breathing, and the facial appearance, they can have flattened malar bones, circles beneath the eyes, a narrow nose, and a prominent upper teeth. So there are a wide variety of medications that are used to treat asthma. There are two main categories: long-term control medications to achieve and maintain the control of the inflammation, and then we've got the quick relief medication to treat symptoms and exacerbations. So bronchodilators, beta agonists like albuterol or levoalbuterol, also known as Xopenex, this helps to relax smooth muscles in the airway. These are the drug of choice for acute or daily therapy. Side effects. In general, you might see tachycardia, nervousness, nausea, vomiting, and headaches. Methylxanthines, your theophylline. This relaxes the muscle bundles that constrict the airways, thereby dilating the airways. These provide continuous airway relaxation. These are used for long-term control, so continuous administration is necessary. These do have a therapeutic level, and so that therapeutic level needs to be maintained in the bloodstream. Generally, the therapeutic level is 5 to 15 micrograms per milliliter, so it is necessary to check blood levels and then adjust the dose based on what those levels are. Lots of side effects are present with this medication. Early signs and symptoms of side effects include nausea, irritability, tachycardia. Late side effects can be arrhythmias, seizures. Additional ones could be restlessness, tremors, insomnia, hypotension, severe headache, vomiting, and diarrhea. Please remember to monitor for signs and symptoms of toxicity. Anti-inflammatory medications. So corticosteroids, they effectively reduce mucosal edema in the airway. Wide variety of side effects with your corticosteroids. Here is increased glucose and sodium, decreased potassium, weight gain, increased appetite, fluid retention, moon face, mood alterations, high blood pressure, and with long-term use, growth retardation can occur. Inhaled corticosteroid therapy like budesonide and fluticasone are examples that can be first-line therapies in children over the age of 5. Although evidence does not show long-term significant effects on bone growth, density, we do want to monitor their growth and the density of their bones and ocular issues, and monitor for suppression of the adrenal pituitary axis every 3 to 6 months if they are in long-term, even inhaled corticosteroids. Salmeterol or Ceravent, this is a long-acting beta-2 agonist. This is used every 12 hours for bronchodilation. This can also be used with anti-inflammatory for long-term prevention. We only use this in children over 4 years of age. Cromolyn sodium, this is a preventative medication, and this is best taken daily to stop chemicals associated with producing asthma. Typically, you want to give this medication at least 10 to 20 minutes before coming into contact with a known triggering agent. This is not a rescue medication. Leukotriene modifiers, basically these medications block inflammatory and bronchospasm effects. They are used for long-term control in combination with the beta-2 agonist and steroids. Singulate or montelukast is used for children 12 months and over. Accolade is approved for 7 years and older. Xolair blocks the binding of IgE to mast cells. This eventually will inhibit inflammation. It is given subcutaneously once or twice monthly for children 12 years and older for moderate to severe asthma that is not responsive to inhaled corticosteroids. This does have a black box warning because of anaphylaxis. In general, as nurses, what do we need to think about? Obviously, maintaining an adequate oxygenation in this child is going to be critical. It may be necessary with a nasal cannula or a mask. And remember, use humidification. They may be positioned in a semi or high Fowler's position. Monitor the vital signs, SaO2 and respiratory effort, and lung sounds. Bronchodilators, medications, and side effects we also have to monitor for, as well as teaching the parents about them. Good hydration is necessary to thin the mucus, monitor strict intake and output, weigh the child, and then promote relaxation due to fatigue. Chest physiotherapy may be necessary, and then peak flow readings are done to see where is the child in terms of their asthma management. These can be done reliably in children 5 to 6 years of age. Ideally, we keep the peak flow meter reading in the green zone. Follow-up. Teach parents chest physiotherapy, inhaled or nebulizing treatments. Teach them the medication regime and the side effects. We want these children to avoid cold fluids and cold air because this can actually cause issues with bronchospasms. So when they're going outside and it's cold, they should cover their nose and mouth with a scarf. Teach parents to be aware of asthma triggers and avoid them. If the child has difficulty coordinating breathing when using an inhaler, they can be given a spacer. Children 5 years old and over should use a peak flow meter to determine how they are doing. This can be done by having the child stand up straight, inhale, and then blow hard and fast into the peak flow meter. This is done 3 times, and the highest result is recorded. It may actually take between 2 and 3 weeks to determine a child's personal best with the peak flow meter. And then once that is determined, they will use it for comparison. And this will be one way to manage the child's therapy. It is done routinely before and after treatments as well. Please remember that swimming is a great exercise because of the type of breathing that is required and the moisture. Bedding and clothes should be washed in 130-degree water. We want to kill any mites that might be causing any issues with the asthma. Also, damp white versus dust. And we really want to think about maybe removing carpets and curtains because of the dust, because this can also trigger asthma. Please be sure to review the care plan in your text. As children hit the age of 5, as they get older, you'll see that they will develop less problems with upper respiratory infections because usually by the time they're 5, they have begun to develop immunity. Lastly, we're going to talk about cystic fibrosis. This is an inherited autosomal recessive disorder involving the exocrine glands that affect the respiratory, GI, GU, skin, and musculoskeletal systems. Body organs and mucus ducts get obstructed and damaged because the body produces this very thick, sticky mucus. Signs and symptoms. There are the 4 F's of cystic fibrosis stool characteristics. So the stool basically looks frothy, foul-smelling, fatty, and it floats. The skin on the child actually tastes salty. So if a parent says, when I kiss my child on the cheek, they taste salty, that would be something we would take note of. They can also have issues with meconium ileus. Here, signs and symptoms would include abdominal distension, vomiting, failure to pass stools, rapid development of dehydrations. GI manifestations include large, bulky, frothy, loose, extremely foul-smelling stools. Early in the disease, they have a very voracious appetite. Later in the disease, they have a loss of appetite, weight loss, and tissue wasting. They can even have a failure to grow. They may have a distended abdomen with thin extremities and very like a sallow-colored skin. And then you're going to see that there's a deficiency in the fat-soluble vitamins, which are vitamins A, D, E, and K. They may also be anemic. Pulmonary manifestations include wheezy respirations initially and a dry, non-productive cough. And then later, they can have an increase in dyspnea, paroxysmal coughs, evidence of obstructive emphysema. They may even develop areas of patchy atelectasis, and then they can even further progress into having a barrel-shaped chest, which is overinflated, cyanosis, clubbing of the fingernails and the toenails, and they often have repeated episodes of bronchitis and bronchial pneumonia. There is a diagnosis, a universal screening test is available across the United States, which is an immunoreactive trypsinogen test. The positive screen identifies children at risk. The sweat chloride test, so a chloride greater than 60 milliequivalents per liter with the above signs and symptoms is obviously problematic. They also will do chest x-rays and examine the stool. A sweat chloride test of 59 to 30 milliequivalents per liter is indeterminate and needs to be repeated. DNA testing for a mutation on the CFTR gene predicts with a high degree of certainty a diagnosis of cystic fibrosis. Treatment. Here what we're going to want to do is prevent or minimize pulmonary complications, prevent chronic Pseudomonas infections, promote nutrition, promote age-appropriate physical activity, and then promote a reasonable quality of life. So respiratory. Here, there are many airway clearance things that need to be done. Things like chest physiotherapy at least twice daily before meals. They may need to do it as many as 3 to 4 times a day. They will be doing the percussion and postural drainage. There's a flutter mucus clearance device, and basically this is a small handheld plastic pipe with a stainless steel ball inside, and this helps to facilitate the removal of mucus. Bronchodilators can ease the expectoration of the mucus. Pulmozyme or DNase decreases the viscosity of the mucus. Some side effects include voice alterations and laryngitis. You want to give daily prior to the percussion and postural drainage or the chest physiotherapy. Antibiotics may be given orally, IV, or aerosolized, so they're inhaled into the lungs. It's very important to maintain an IV access, and it's not uncommon for these children to have a PICC line or a central line. Nutrition. Here they need to have pancreatic enzymes, the pancrelipase, with meals and snacks for digestion of the nutrients, and then we also want to decrease the fat in the stool bulk to 2 stools a day, and that the enzymes will help with that. They need water-soluble forms of the fat-soluble vitamins, again, which are the vitamins A, D, E, and K. They need a high-protein, high-calorie diet. They may actually need up to 150% of the calories to meet their growth needs. They may need an increase in salt intake due to a loss in sweat or when there is an increase in exercise, fever, or hot temperatures. Meconium ileus obstruction or constipation can occur. Here, treatment involves colightly, Miralax, and laxatives, stool softeners, or even rectal administration of gastrografin. Rectal prolapse can occur in 20 to 25% of the cases. Here we're just going to very gently, with a lubricated gloved finger, guide the rectum back into place. We want to decrease the bulk of the daily stools with the pancreatic enzymes. Average lifespan in 2015 was up to 40 years of age. So this concludes part 3B of this lecture. So this is week 3 objectives, part B. Please be sure to read your textbook and complete the assignments for this week to facilitate the utilization of this content and apply it to nursing practice. Thank you and have a good day.